And so this session is dedicated to the immune system and its effect on cancer, either manipulation of the immune system to combat cancer or defects in the immune system which can lead to cancer, as well as unique ways that cancer is able to evade the immune system. And so we have some very interesting talks today that will begin with Dr. Holly Miller. Dr. Miller is a third-year pediatric hematology oncology fellow. She is also the Immuno-Hematology subtract fellow. And so Holly has really worked very hard and done some very nice work in our clinic, taking care of our immunohematology patients. And we're very excited for her to continue her immunohematology career. She has had several nice offers for some great programs to continue her work in immunohematology. But Holly's going to discuss a very interesting patient that has an IL-10 receptor defect and explain a little bit of how this defect can lead to disease in both autoimmunity and cancer. And for the speakers for this for the afternoon sessions, I just want to remind everyone is that because of the streaming capability, that when the speakers are up here, it comes across very well, but it's been difficult to hear the audience questions. And so if you can please repeat the question before answering.
Hi, my name is Holly. I'm going to talk about a patient with an IL-10 pathway defect that led to Crohn's disease and lymphoma. I have nothing to disclose, but I am bad and did not put that slide in my presentation, so I apologize. So our patient presented to us at about 12 years of age with a history of severe refractory fistulizing infantile Crohn's disease and presented with a concern for malignancy to our oncology program. She had a 2-month history of right-sided abdominal and back pain, as well as a 1-day history of fever, but denied any night sweats or weight loss. However, she has a significant history of failure to thrive due to her severe refractory Crohn's disease. She also had palpable splenomegaly, but no palpable lymph nodes. Because of the concern for malignancy, we ended up ordering a CT scan as well as PET scan on her. The CT, as you can see here, showed massive hepatosplenomegaly with multiple liver lesions, as well as multiple enlarged lymph nodes in the mesentery, as well as the porta hepatis. And the PET scan showed increased FTG uptake throughout the liver and the local lymph nodes. However, everything was localized below the diaphragm. On liver biopsy, frozen section demonstrated malignant small round blue cell tumor, which was positive for CD45 and CD20, but was negative for CD3, CD4, CD5, CD8, CD56, and EBER staining. Her ultimate diagnosis was diffuse large B-cell lymphoma, which was EBV negative. She was treated with an aggressive non-Hodgkin's lymphoma protocol, and at the end of therapy, she still ended up having positive PET imaging. Because of this, she received some additional cycles of chemotherapy, after which she developed several infectious complications, resulting in decreases in her chemotherapy as well as delays in her chemotherapy. At the end of the additional chemo, her PET scan was negative. However, her CT scan, even though it showed some lesions, as you can see by the arrows on the screen, showed a marked reduction in the multiple low attenuation hepatic lesions. So she was considered to be in clinical remission at that point in time. Following completion of her chemotherapy, she was actually able to be transitioned from TPN to G-tube feeds and then subsequently to full oral intake. She ended up having some excellent weight gain following her initial chemo and ended up having her G-tube removed and her gastrocutaneous fistula closed. Her Crohn's disease remained quiescent for the first time in her life, and she was actually able to be removed off of immunosuppressive therapy following chemo. However, 2 years after completion of her chemotherapy, she presented for routine imaging, labs, and physical examination. On her return appointment, she was asymptomatic. However, lymphadenopathy was palpable on examination. Her abdominal CT and PET scan were positive for hypermetabolic liver lesions, a large retroperitoneal mass, as well as hypermetabolic lesions in the neck and the chest. Biopsy was obtained again of the retroperitoneal mass and it demonstrated malignant small round blue cells which were CD20 positive and EBR negative, very similar to her first presentation. She then received reinduction with high-dose chemotherapy and was able to achieve radiological remission following 3 cycles. Because of her remission, we were planning on moving forward with myeloablative chemotherapy followed by autologous stem cell rescue for treatment of her relapsed lymphoma. However, new literature was reviewed around that time which described IL-10 and IL-10 receptor deficiencies. These patients tend to present with very early onset inflammatory bowel disease, where colitis occurs within the first year of life. In the patients with IL-10 and IL-10 receptor deficiencies, the colitis typically occurred within the first 3 months of life for these patients. The colitis is often severe and results in several fistulizing lesions and responds very poorly to standard immunosuppressive therapies. A lot of these patients also developed EBV negative mature B-cell lymphomas, very similar to the one our patient had developed. So just looking at this point in time, when we thought of the IL-10 and IL-10 receptor deficiencies, we decided to review her Crohn's disease a little bit further. At 2 months of age, she was diagnosed with necrotizing enterocolitis. However, she did not have any surgical intervention or biopsy done at that time. She just had severe abdominal pain with abdominal distension, with abdominal distension and diarrhea, but no intervention. At 5 months of age, she had her first colonoscopy, which was diagnostic of her Crohn's disease. At 8 months of age, she then developed multiple fistulizing lesions requiring colectomy. And between 1 and 2 years of age, she had multiple admissions for her Crohn's disease flares as well as failure to thrive, resulting in some changes in her immunosuppressive therapy. And then at 5 years of age, she ended up developing an abdominal abscess as well as more fistula formation and respiratory failure requiring ECMO and CRT support. From 6 to 10 years of age, she continued to have several medication changes due to her refractory and severe Crohn's disease. At age 12, she was diagnosed with her lymphoma, and at age 13, she ended up having pneumonia, Klebsiella bacteremia, MRSA and Candida infections, and Sucromurella, which is an acid-fast bacilli infection as well. However, her Crohn's disease became rather quiescent around that time. And then at 14 years of age, she ended up having a lymphoma relapse requiring reinduction chemotherapy and stem cell transplant, as well as worsening of her Crohn's disease. So a little bit about IL-10 and IL-10 receptor signaling pathway. IL-10 is an immunosuppressive cytokine, which is produced by regulatory cells. In particular, monocytes tend to be the largest producer of them. IL-10 receptor is a heterotetramer that's expressed on most regulatory cells and tends to be upregulated on cell activation. IL-10 receptor alpha is unique to IL-10. However, IL-10 receptor beta is shared by other cytokine receptors, including IL-22, IL-26, and interferon gamma. So when IL-10 comes in and attaches to the IL-10 receptor, STAT3 is then phosphorylated and is allowed to move intranuclearly to allow for the transcription of anti-inflammatory genes. It plays a huge role in limiting or terminating inflammatory responses of immune cells by blocking the NF-kappa B dependent signaling. IL-10 receptor signaling is also critical to gut mucosal homeostasis, promoting the suppressive functions of regulatory T cells and preventing exaggerated Th17 responses. So when IL-10R receptor is absent, this leads to unregulated gut inflammation, which is the cause for the severe fistulizing Crohn's in these patients. So because of the high suspicion of the IL-10 deficiency in our patient, we ended up doing STAT3 phosphorylation assay, which identified absent signaling through IL-10. Because of this, we ended up sending flow cytometry for IL-10, which was found to be decreased in our patient compared to controls, as you can see by this red peak. Sorry, there's no, oops, there's no arrow, by the red peak being moved to left on the patient sample compared to controls. We then performed sequencing of her chromosome 21, which demonstrated a compound heterozygous mutation for her IL-10 receptor beta. In review of literature following this, looking at clinical phenotype of patients with IL-10 receptor defects, Kotler's and others screened 66 children who all had inflammatory bowel disease diagnosed under the age of 5 years. 16 of these patients had IL-10 or IL-10 receptor defects. And in the patients, of those 16 patients that had the IL-10 or IL-10 receptor defects, 100% of them actually had colitis within the first 3 months of life. 100% of them also had cutaneous folliculitis, and 25% of them had arthritis as well. Then a year later, Nevin and others ended up documenting 14 patients with a loss of function mutations in the IL-10 receptor protein. And 36% of these patients ended up developing EBV-negative diffuse large B-cell lymphomas. And then also in 2013, Engelhardt and others identified stem cell transplant as a potential curative therapy in these patients. So they had 9 patients, 6 of which did not undergo stem cell transplant and 3 of which did. Of the 6 that did not undergo stem cell transplant, they had severe IBD with perianal disease that was refractory to immunosuppressive therapy and required multiple surgical interventions for their management. The 3 patients that underwent stem cell transplant, they were all able to have sustained remission of their inflammatory bowel disease, as well as resolution of any fistulas and improvement of their overall nutrition. All 3 of those patients had survived. When looking at IL-10 receptor deficiency and why we believe it predisposes patients to cancer, since IL-10 is responsible for blocking NF-kappa B signaling for inflammation, when you take this away, you end up having uncontrolled inflammation, which results in the very early onset IBD, as well as results in further B-cell proliferation. With the proliferation, you're always going to have some accumulation of mutations. However, when you have the knockout of IL-10, particularly in the beta receptor, you lose the interferon gamma co-stimulatory molecule, and this results in defective immunosurveillance, which then can lead to development of lymphoma. So because of the study where the allogeneic stem cell transplant seemed to be curative for not only the lymphoma, but the severe Crohn's disease or inflammatory bowel disease, we decided to pursue allogeneic transplant in lieu of autologous transplant for our patient. So she underwent an allogeneic MASH unrelated donor transplant with reduced intensity chemotherapy. She had multiple comorbidities at the time of her transplant, including very poor nutrition being a major factor. She's currently more than 1 year following her transplant and has had no relapse of her lymphoma to date. She's actually had no evidence of graft versus host disease either. Her Crohn's disease has been in clinical remission since her transplant, and her chronic folliculitis has resolved. However, she still, to this date, has some very poor wound healing, likely due to all the scarring from the chronic folliculitis. Any questions?
So great talk and a great story, actually. Knowing that we saw her like with the beginning part of what we saw, it's a really phenomenal story. What, from your review, what did you find from those other patients who were transplanted? Have they remained in long-term remission from either second malignancy, second lymphoma, leukemia, as well as the Crohn's longer time, more than 1 year?
So Dr. Modi's question was, for the patients that underwent stem cell transplant, were they able to sustain prolonged remissions of their Crohn's disease as well as their secondary malignancies and other complications such as the folliculitis that they tend to get? The follow-up for that was greater than 1 year out, and I believe the follow-up was about 2 years for one of the patients. It was a little over a year for the other, and the other was a little bit longer, but they all had sustained remissions.
In lab-wise, in our patient as well as for those patients to normalize their IL-10, they've corrected all their lab abnormalities that you would see with this pathway. I don't know, what is the
So
phenotype?
the question was, did they normalize all their laboratory abnormalities associated prior to their transplant? And that I cannot recall. Thank you.